Welcome to the CBIA BizCast. I'm your host, Ali Warshavsky, and today on our podcast, we have Chief Medical Officer Dr. Adam Seidner of the Hartford. Now, he is here to discuss the company's new partnership with the Yale Program in addiction medicine. Their goal is to develop a program for Connecticut medical providers who treat injured workers, focus on addiction, pain management, and the stigma. Welcome, Adam.
Thank you. Glad to be here today.
First, just want to know a little bit about you and your background. How long have you been with the Hartford?
I've been with the Hartford 4 years now, and I've been working really with them to curb the ongoing opioid crisis, which is part of the Hartford Yale initiative as well. But I've been working really on the opioid crisis now for probably closer to 12 years.
Wow. And is that something that, you is close to your heart, something that you have become really involved with for any particular reason?
Yeah, there's a number of reasons. I mean, obviously, for patients, for workers, but, it's affected my colleagues, it's affected their families, it's affected friends. And, unfortunately, there's probably many people in the country that have lost loved ones to the opioid crisis.
And what inspired, we know now why you have gone into studying it, but what inspired the Hartford to partner with Yale?
Well, we were partnered with a number of different organizations around the country to advance our initiative, really. And the Hartford's approach is multifactorial. I mean, we want to support the community by also having a social competency as well as in our claim management. So we have to understand the healthcare systems that we're part of. We're always involved in the education and health literacy aspect of the individuals and the treating providers, as well as I mentioned, the community and the social context in the workplace. So all of that comes into how we manage our claims and advocate to make sure that all the resources that are available are identified and aligned so that they can help better engage the injured worker, the doctors, the employers.
And now I read that phase one of the pilot program is underway. So what is happening right now? Are employers, employees actively involved in a maybe webinars or some type of program to learn how to address the crisis? What exactly are people involved in this program doing as we speak?
Yeah, so phase one really is the development of these training modules for the medical providers, and also to identify those resources to develop a compendium of clinically relevant resources. So what we're going to do is train the medical providers on addiction, on pain management, on the stigma associated with all of this. It's just important to know that we have a lot of opportunities here, and both organizations, the Hartford and Yale, have been involved with educating and working with the treating provider community.
So that was phase one, and phase two is set to kick off in January. What does phase two entail specifically?
So in phase two, which will go through the first 2 quarters, the first half of 2022, we'll actually start delivering the training to 50 to 100 Connecticut physicians who treat workers and manage, acute injuries, which means acute pain, the chronic pain, if and when they develop it, as well as substance use disorders. Now, we need to understand that acute pain, if properly managed, can prevent people from developing chronic pain. And again, when pain is properly managed, many people can resume their lives. So we really need to focus on keeping people active and pain-free.
It's very true. If you have a back injury, but then you continue to overdo it, right? You might get to that point where it's no longer acute pain. And for so many of us, it's just so hard to stop. So is this program, and you explained it a little bit, but is it more about identifying the solutions to pain before opioids are prescribed, like you mentioned, that acute pain care, or is it to help those addicted get off the medicine, or is it a little bit of both?
It's all of the above, and it's going to vary. So I think we need to understand that the main focus is on the patient, and everyone comes in with their own background. So we have to understand the patient's health beliefs, the health literacy, so that when we communicate, they understand what we're saying. And we also have to understand a little bit about them. Do they have good self-efficacy? Meaning, are they going to actively participate in their recovery? And if we identify that they don't have the skills and or high self-efficacy, what are the interventions that we're going to do there? And then there's finally really understanding the patient's expectations and managing those expectations, because some of them are reasonable, some are not reasonable. And so we need to address all of that. And there's a model out there that we're looking at and using parts of called shared decision making. So once we really understand what the patient's expectations are, what their capabilities are for participating in their care, being able to make sure that they get the services that match their needs.
And now, have you seen the Hulu show Dope Sick?
I have seen parts of it, yes.
Do you think, this really made me think at least, that there is a misconception of opioid addiction, because in Hulu, or in Dope Sick, I should say, on Hulu, you see it's the hardworking coal miner or farmer that's prescribed this prescription to keep working. They want to be able to put food on their table. It's not because they just wanted to get high. So do you think that there is a little bit of misconception of who becomes addicted to opioids?
I do. I think that that's a good point, is that a lot of the people are not taking the medications to, change or alter their mental status. They're trying to stay functional. Some are trying to feel okay, good enough to work. So I think we need to level set with the treating providers and get them to understand that we have other methods besides pharmacologic and alternatives to opioids if we are using pharmacologic interventions, but also non-pharmacologic. There's many different other options that we can reach to help patients stay functional and avoid the addiction. Because anybody, the way we're set up, these medications work because we have pain receptors. We have receptors for the medications. And so anybody who takes the medication for a long enough period of time on a constant basis will become physiologically dependent on the medication. And I do make a distinction between addiction and dependency. The addiction really starts to point to behavioral changes in the individual in trying to acquire these opioids, where, a physiologic dependence, they may or may not understand that their body now needs that, but if they did stop, they'd undergo a withdrawal. So there is a little bit of a difference between the dependency and addiction.
So when it comes to the dependency, like you just said, versus addiction, it seems like you don't even have to be on them for that long to feel dependent on them.
And again, the dependency can be physiologic, meaning just the way the body's functioning, it's now dependent on them, or it could be psychological. So the dependency can be at two levels, but really the physiologic dependency can occur in as short as 5 to 7 days for some people, meaning if they, stop the medication after a week, they may actually experience some withdrawal symptoms.
In more recent research, which I'm sure you know off the top of your head, but for our listeners, the Hartford collaborated with Shatterproof on a Stigma survey and found a lot of people, even today, don't understand addiction. And unfortunately, that stigma also crosses over into healthcare workers. The Addiction Stigma Index showed that 75% of the public do not believe that a person with substance use disorder is experiencing a chronic medical illness like diabetes or heart disease. And 65% of healthcare workers reported SUD is not a chronic medical illness. The stigma among healthcare workers seems concerning. How are you helping to change that?
And again, going through the evidence and really getting the training to physicians that they may not have received formally during their medical school or residency training, or even in their continuing medical education. And so it's important that people understand where the patients are coming from, why they may be behaving in a certain way, and what are the best ways to address any of the issues that come up.
Do you think employers need better training to help spot addiction? And how can employers help? It seems like it might be an awkward conversation for them to have.
Yeah, there's a number of different things that employers, I think, should be looking at, especially as we're coming out of this pandemic, is they should be looking at their policies and procedures from a number of different perspectives. But with regard to, other medications that are being used and their impact on how people can function in the workplace, above and beyond, the opioids, and even in some areas, where medical marijuana may be involved, they need to have identified the jobs very well and what the job descriptions are, as well as if they're safety sensitive aspects to the jobs. And having that in the job description gives the employer a lot of opportunity to do some interventions when necessary. And then there's training of all of the supervisors and what resources the company may or may not have, and getting those resources in place. For instance, some of our customers have engaged in additional resources besides just the medical professionals, but there's a whole area of digital therapeutics now. And digital therapeutics are an adjunct, and some are prescribed by the physicians. Now, if the physicians aren't aware that they can prescribe something called Reset or Reset-O, which is for substance use disorder or opioid use disorder, then that's a missed opportunity. And what that does is give support to the employee as they're working through any of these substance use or opioid use disorders.
This digital therapy, how does that work? Can you explain that a little bit more?
Well, there's many different levels at which it works. So it could be as simple as, keeping track of their pain. What level is their pain today? And is there an opportunity to use a non-pharmacologic intervention to help them with that? So as part of that, there's mindfulness and relaxation techniques and things like, the yoga and all that, which really have shown to be helpful. So that's just one level of keeping kind of a diary, but also, are they using the medication appropriately? Are they escalating the use? That would be identified as well as they kept the diary available. And then the other thing is sleep may be part of a lot of these modules, because if you're not sleeping well, you're not going to perceive the pain appropriately, and so on and so forth, up to and including support services, which could be groups that individuals could join and learn from other people who have dealt with and are dealing with substance use or opioid use disorder, including and up to including, again, these digital therapeutics can have a wide array of services, having a counselor, a health coach, or even making potential recommendations that they need to see their physician.
And my last question for you is, I was reading the op-ed by the Hartford CEO, Chris Swift, and he suggested that we stop using the words drug abuse and say substance abuse disorder, and eliminate words like junkie. How important is the language change behind breaking the stigma?
And I think that's critical to breaking the stigma. And that's why not even using the term abuse and just using the term substance use or opioid use, it has less connotations associated with it. And again, thinking of it as a chronic disease model, we have people with high blood pressure and diabetes and heart disease, and really it's very similar in how our body responds. There's chemical transmissions that go on, and all of that needs to be identified and used appropriate language so that we can also bring in an integrative approach and use multimodal interventions, because the personal care of these individuals, as well as workplace factors, are critical, and we need to make sure that they feel comfortable in the workplace, the training of supervisors so that they feel comfortable at least asking the question if there's an issue, knowing when maybe they need to refer to an additional resource through EAP, the Employee Assistance Programs, or HR. There's a lot of opportunity out there.
Well, Adam, thank you so much for coming on this podcast. I want to open up the floor to you. If there's anything else you want to mention about the program and you think that we didn't touch on.
No, just that there are a lot of tools and resources out there that listeners can look at. And again, what we'll be doing is packaging it in a way and translating it and transmitting it in a way that maybe helps it stick with the providers easier. But so SAMHSA, there's the Substance Abuse and Mental Health Services Administration. We're working also with NAMI, which is the National Alliance on Mental Illness. You mentioned Shatterproof already. And then there's also NIDA, the National Institute on Drug Abuse. And the other part of all of this is the proper use of some tools that are in place in many of the states. It's something called a Pdmp, which is a prescription drug monitoring program. And so the doctors are able to go in and see what controlled substances their patient have been prescribed, who prescribed them, and to make sure that they're going to be more comfortable if they're going to continue prescribing a controlled substance with their patient.
Well, thank you so much for joining us, and we look forward to having you back on maybe in the spring to talk about how well the study went, hopefully, and what else you have planned. Thank you for listening to this week's BizCast, and subscribe to other BizCasts on Apple, SoundCloud, YouTube, and you can catch other episodes at CBIA.com.